Cancer Corner. Coosa Valley Regional Cancer Center here in Sylacauga, and there's 8 or 10 of the
8
facilities. Okay, and you're in the
Anniston and
area?
Fort Payne.
Yeah,
occasionally down in Tuscaloosa, occasionally here in Sylacauga as well, and we're expanding and growing all the time.
You're all for the basketball tournament last week.
Yes, so I had off last week. I'm from Tennessee originally, and our little school, Oakdale, Tennessee, was for the boys in the state basketball tournament for the first time in history.
All right, fantastic.
Unfortunately, got eliminated first
round. That's okay.
round.
They made it to the first round.
Yep.
A lot of teams did not. So we're talking about, and we have for several weeks now, about some of the myths and truths of cancer. Where are we going today?
So I thought now would be a good time to get more into the nitty-gritty of cancer, which is how's it diagnosed, how's it staged. And there are so many different cancers, as we have alluded to in our previous weeks that we've been talking. And I thought instead of maybe trying to cover how is cancer diagnosed and staged in a general sort of direction, I thought we could talk about it for prostate cancer, which is a very common cancer. Almost probably, the statistics say up to 1 out of 3 men, if you live long enough, are going to be diagnosed with prostate cancer in their lifetime. So I thought we'd start there with diagnosis and staging of prostate cancer. What is prostate cancer? Well, obviously, your prostate, it's a male sexual organ. It sits right underneath the bladder. Anytime you urinate, actually urine passes through the prostate out through the body. So, and it sits there as well to provide sexual function. It actually helps with, fertility and sperm and that sort of thing. It's a gland, like a salivary gland, for example. Your salivary gland makes spit. The prostate gland helps make prostatic fluid. And a lot of glands in the body are prone to get cancer. Actually, the breast is a large milk gland to some extent. So that is a good example of an organ that contains glands that can get cancer. So prostate cancer is a cancer of the prostate, that part of the body. It's pretty small. It's about the size of a tangerine, or a little bit smaller than a tangerine usually, so it's not a very big organ. And any cancer is just uncontrolled cell growth. Usually cells in your body are constantly dividing and dying off. And really a cell is a cancer cell is a cell that is dividing and no longer listening to the proper cues as to how to die and how to replicate properly in the body. And also a cancer cell, the way that cancer can become deadly is when these cells break off and travel to other parts of the body and then begin to invade other organs, causing problems in those other organs. Now there's an exception to every rule. Everything I'm saying, in the back of my head, I know there's a slight exception to it, but that's sort of the broad overview. So, prostate cancer, uncontrolled cell growth inside the prostate.
Prostate cancer, very common among men.
Very common. As I mentioned, up to maybe 1 out of 3 or 1 out of 2 men over the course of their lifetime. Let's say if you live to age 85, you've got about a 50-50 shot of having prostate cancer.
Why?
We don't know exactly. We know that the prostate is a very active gland throughout a man's lifetime. A man's prostate makes fluid throughout his entire lifetime, but that's a good question. We don't have a great answer as to why it's so common. Now, the thing about prostate cancer is, since it is so common, you wonder, well, why aren't more people dying of prostate cancer if it's so common? Because it's not the #1 cancer killer in men. Lung cancer is still the #1 cancer killer in men. But about 250,000 men a year in the United States are diagnosed with prostate cancer. Only about 25,000 men a year die of prostate cancer. So obviously it's not a very aggressive cancer. A lot of times prostate cancer will come about and get diagnosed, and this is evolving over time, we can recommend for many men with prostate cancer to not go immediately to treatment. We can observe it because obviously some of the treatments for prostate cancer can have side effects.
How's it found?
So how is prostate cancer diagnosed? This is going to be different from man to man, but over the past decade, over the past 2 decades, the most common way that prostate cancer is found is due to a PSA blood test. Now, in previous weeks, we've talked about the PSA blood test a lot. We've mentioned it as one of the primary cancer screenings that we do in the United States, is to draw a PSA on men that are 50 years or older, and we recommend that yearly as a screening recommendation. Now, that's gone back and forth, so again, I'm just speaking sort of generally at this point in time. Now, you can have urinary problems, you can have blood in your urine. Occasionally men will have prostate swelling, go in to see their urologist. The urologist will do a minor procedure on the prostate, not looking for prostate cancer, but get some cells out of the prostate, and they look under the microscope and go, oh, lo and behold, you've got prostate cancer. We had no indication of that. Those things like that, having symptoms or having it found incidentally as a result of a other minor procedure, are kind of rare. So usually most men get diagnosed with prostate cancer as a result of having this elevated PSA test. But just because you have symptoms or just because you have an elevated PSA, that does not mean you have prostate cancer. I think another common misconception that people have is that we can find cancers just on the basis of having a scan. In other words, you have a mammogram, for example. Going for a mammogram, they say, well, we found the cancer on the mammogram. Yes and no. We found a spot on the mammogram, or we found a spot on the scan, whatever that scan might be, a CT scan or MRI. But that spot in and of itself, while suspicious, doesn't equal cancer. For the vast majority of patients, and this is true for almost any cancer, the way that we find a cancer is we have that suspicion, whether it's an elevated blood test or whether it's a symptom, and then we go in and we biopsy that area. And the word biopsy means we're going to put a needle in there, or maybe just via whatever method, take some cells out of that organ or out of that part of the body and look at them under the microscope. And so you have an illustration here of something that we call the transrectal ultrasound. That is a probe, the ultrasound probe that you see labeled there, and it goes up through the anus and into the rectum, and you can see the location of the prostate there. You can see the bladder above the prostate to the left here on this picture, and you can see then the penis and the testicles over to the right, the rectum behind the prostate, and so you can see a tiny little needle there coming out of the probe up into the prostate. So we get a small amount of tissue out of the prostate, but in that small amount of tissue, there can be millions of cells. And then a doctor called a pathologist will look at those cells under a microscope, and pathologists are experts at making diagnoses of cancer looking under the microscope. But that is the absolute 100% agreed upon method of diagnosing prostate cancer, is seeing the cancer under a microscope.
Now, as a man, just looking at the screen of what is done to begin with, that causes you to cringe. Men, we're kind of private anyway. So
it's just not a. It's a very tender part of the body. It's a very touchy part of the body. And it's a part of the body just in general, mentally. I know I'm this way. You don't really want to think about it, and you don't like thinking about it. So, but, sometimes, like Don Rumsfeld said, you have to go to war with the army you have versus the army you want. So sometimes you're in a situation, and we can all agree that maybe you need to go have your PSA checked from time to time. And if there is an abnormality, the last thing you want to do is, I don't want to think about it. I just have an elevated PSA, and I don't want to follow up on that, and I don't want to go see my doctor and get additional tests done. That's the last thing you want to do, because as scary as that picture is, that's a few moments in time that you might be able to fix a cancer. And a cancer will be with you, untreated if it's incurable forever and cause you a lot more discomfort and pain than having a probe, which, again, it's uncomfortable. It's not going to be the most fun you've ever had in your entire life. And most men actually have this procedure under anesthesia. So you're put to sleep the vast majority of the time. Put to sleep, so, obviously.
That makes you feel better about it.
Yeah, obviously when you're asleep and you have this biopsy done, you're not going to feel anything. You wake up, you recover. You have a few days of blood in your urine, and that's usually the extent of it. 1 out of 1,000 times men can have an infection from the biopsy and that sort of thing. Now, one thing that I want to mention, so, we talk about having an elevated PSA. What is a normal range of PSA, 0 to 4? I think we mentioned that on one of the slides there. So let's say you have a PSA, you go to the doctor and you have a PSA of 8, for example. Everyone would agree that's kind of suspicious. Now, the way that this has been done traditionally throughout the United States, throughout the world for that matter, is on the basis of that suspicious PSA, you would go immediately to this ultrasound-directed biopsy. Now, what would ordinarily be done if you put up that picture again of the biopsy, the ultrasound picture, is they will take that needle and go more or less randomly throughout the prostate. Top of the prostate, middle of the prostate, to the bottom of the prostate, which on the picture here from the left to the right of the prostate. And they'll try and take 10 or 12 samplings throughout the prostate. Again, sort of blindly, if you will. And the problem with that is that we might miss the cancer sometimes, because let's say, the prostate's small, but let's say the cancer was only the size of a pea, for example, and then you're just randomly biopsying throughout the prostate, and you have a PSA of 8, and then the results come back negative for the biopsy. Negative means no cancer found. Negative doesn't mean bad. Actually, negative means good. So then the results come back negative, no cancer found. Maybe we missed the cancer in that situation. We've always had that worry, but we didn't have anything better to do. And let's say, a year later, the PSA goes up to 10, we do the biopsy again, and then we find the cancer at that point in time. So then we can think back and say, well, gosh, maybe we missed the cancer a year ago. So now we have, just in the New England Journal of Medicine, actually just published this week and presented at the International European Urology Conference, a new paradigm, if you will, of thinking about how to biopsy these prostate cancers. And that paradigm is looking at doing an MRI, and an MRI is a special sort of scan. You can call it an X-ray, but it's not an X-ray at all. It's actually using radio waves to look inside the body, and everyone's heard of an MRI. They're very safe. They're very easy to do. It's completely non-invasive. You think about that picture, that distasteful picture of the probe. Yeah, stuck up your rectum. Yeah. The MRI is just, you go into a tube, you lay down in a tube. It's noisy, but you're lying flat on a table and nothing is invading your body. So the idea was, we did a randomized trial of about 500 patients. We followed them over a period of time. And for about 250 of the patients that had an elevated PSA, and on average in this study, the PSA was between 6 and 7. We took 250 of the patients, and we did it the old tried and true way, which is just go and do straight to ultrasound biopsy and do the random biopsy throughout the prostate. Now, when you do it that way, this study showed, and we were already familiar with that data to some extent, you had about a 50-50 shot of finding a prostate cancer in that situation. About 52% of those patients had no cancer. About 26% of those patients had a significant cancer. And we'll go over what that is in just a minute. And about 22% of the patients had an insignificant cancer. When the patients went on and had an MRI first, about 28% of those patients had a totally non-suspicious MRI, and we could say to those patients, we aren't even going to biopsy you. We aren't going to go and stick the needle on your prostate or do anything like that. For the other approximately 72% of patients, for the other approximate 3/4 of patients, about 52% of those had a significant cancer, and only 13% of those had an insignificant cancer. And out of the 72%, 35% had no cancer. So clearly, if you just look at those numbers, the MRI was a much more efficient way of doing things. We could take, instead of just blanketly applying an ultrasound biopsy to everyone, we could eliminate a biopsy for a significant portion of the patients. And then for those patients who we sort of selected to go on for biopsy, we found a much higher rate of significant cancers in those patients. So now, at this point in time, we can sort of agree in medicine and on the basis of this study that anyone with an elevated PSA should be going to a facility or a center that is doing this MRI-based sort of not only screening, I would call it a screening, even though they didn't necessarily say it in this study, but we screen people with an MRI, and if you have a suspicious MRI, then you go on to the biopsy. If you have a non-suspicious MRI, then we can say no biopsy for you, and it really is a more efficient way of doing things. The drawbacks are, at this point, number one, not every radiologist, and a radiologist is a doctor that specifically is trained in reading MRIs. Not every radiologist in America at this point in time is really facile with doing these MRIs of the prostate and this sort of standardized way that we read MRIs of the prostate. And then the other thing is not every facility then, because after you have the MRI, the urologist needs to use that MRI to be the basis for the ultrasound. So instead of going in and blindly sampling all over the prostate, they need to sample where the MRI said this is a suspicious spot inside the prostate. Now, I know they are doing that at facilities in Birmingham like UAB and the other hospitals in Birmingham. We aren't doing it in Anniston routinely yet. We're not doing it here yet.
So you see that evolving, however?
It's got to evolve. It's got to evolve because men need to have access to this level of care. And as a matter of fact, the insurance companies, when we've recommended this for patients, the insurance companies have denied it. Now they really can't deny it anymore because this is recognized as being the more correct and maybe even the correct way of doing things and diagnosing prostate cancer. If you show, we have one slide, and I thought this was interesting. It's a bar graph slide that shows the MRI results. This, what I was alluding to about the MRI being suspicious or non-suspicious, it's called a PI-RADS score. And the PI-RADS is sort of a prostate information, and then the RADS is an acronym for something about the radiology score. And anything that was a 1 or a 2 was non-suspicious. And we consider suspicious a 3, 4, or a 5. It goes all the way up to a 5. And in this study, if you had a PI-RADS 3, you had about a 12% chance of having significant cancer, 22% chance of having an insignificant cancer, about a 2 out of 3 chance of having no cancer. But if you had a PI-RADS 4 or 5, you can see at a PI-RADS 5, it was essentially a 94% chance that you had a cancer, only a 6% chance that you did not have cancer. So it may be, as we get really good at reading these MRIs, when you have a very, very suspicious MRI, we may, at that point in time, not do the biopsy anymore because the MRI is so informational in terms of telling us whether or not you have cancer. There's going to be caveats to that, and we'd have to study that over time. But it really is, you know, just coming out this week, sort of a breakthrough in prostate cancer for men. A
lot of men watching this show, a lot of granddads watching the show, a lot of spouses of their husbands and the grandfathers watching this show today. Can this type cancer, prostate cancer, can it lie dormant? And what is, you know, what you shared this morning, and I'm just talking about, because I know these people watching, a lot of them.
Right.
And what is it that is going to spur us men to more action?
Well, hopefully I am, to some extent, coming on here every week and saying, go get a PSA if you're 50 years or older. And really, that's really all you have to do. And if you think about it, the vast majority of the time that you go and get your PSA checked, it's going to be normal, you're going to be fine, 95, maybe even 99 times out of 100, that check is going to be okay. So then that's good. I would say it's better to know than not know. I would say, again, and I didn't intend to talk about treatment of prostate cancer today, but don't let the treatment of prostate cancer scare you too much. The treatments are getting better all the time. As I've mentioned here before, the men I treat for prostate cancer will come in and get their treatment in the morning and then go out and play 18 holes an hour later after the treatment and be okay and not really have any recovery time. Now it's different if you have surgery, and some of the other treatments for prostate cancer can be scary. In my opinion, not as scary maybe as that picture we've shown of the ultrasound probe this morning, but there's good news. And look, I think, we can be scared, but to me, a death from cancer is more scary. To me, not being with my loved ones and not being there with my children and my grandchildren would be a much more scary proposition. We have to face it, our bodies wear out. Our bodies are machines and they wear out, and we need to sort of, just like with anything in life, sort of take care of them, this blessing that we're given of life. I don't know if that answers your question or not, but that's my take on it.
Well, those are some questions that's off the beaten path this morning, but a lot of people think that way, and but there are a huge number of cancer survivors, and some even come through the studio that's been treated by you folks.
Yeah, absolutely. It's been interesting. I will meet people here in the studio and say, "Oh yeah, you're a former patient of mine," and that goes back to one of the fundamental questions we asked probably in the first week. Will we ever find a cure for cancer? Yes, we find it 7 days a week. We find it all the time. We're curing people all the time. People are living, 10, 20 years after their diagnosis. It is still a lethal disease. It is still, if not the number one killer in America, the number 2 killer behind heart disease, and probably will be that way for a long period of time. But we're doing better and better and better all the time of taking care of these cancer patients in general, especially prostate cancer.
Final thoughts with Dr. Todd Scarbrough here at Cancer Corner from Alabama Cancer Care. Final thoughts from you this morning.
My final thought would be, and we probably don't have enough time to dive into it very deep, is that after you get your prostate cancer diagnosed, as doctors, we go through a staging process. Most men who get diagnosed with prostate cancer are stage 1 and stage 2. That, it goes all the way up to stage 4. We recognize earlier stages as being more curative. People need to realize these stages are man-made. They change over time. The stage one, definition for stage 1 today may not be the definition for stage 1 5 years from now. My final thought would be, go see a cancer doctor, go get your screening. For prostate cancer in particular, go talk to your primary care doctor. Get a PSA when you get up above age 50, and take care of yourself.
The one cancer rule of this man-made stages, what would that be?
It would be that we can assign a stage to someone, but that does not mean that your future is set. People will come to me after they've seen other cancer doctors, and they'll say, well, my doctor said I was this stage and they gave me 12 months and here it is 3 years later. Well, to some extent, that can be correct, but it's also, each patient is an individual. And I can assign you a stage and I can say it's going to be this way, but I don't know the future. No doctor is God. And so the best thing you can do is just in your own mind, like I've said, take care of yourself, listen to advice from the doctors, but these things will change over time, and the best thing we can do as doctors is participate and interact with our patients and give them the best care possible.
How can people find out more about Alabama Cancer Care?
Go to our website, look us up on the web, alabamacancercare.com. You can find us on Facebook, social media. You can find me on social media, and pop into one of our centers anytime if you have a question. We'd be glad to talk to you.
All right, Dr. Todd Scarbrough, our guest this morning, and our topic this morning on Cancer Corner has been prostate cancer. We always appreciate you coming, and every Thursday morning we look forward to next week as well. And you know what? Our basketball team will get better, and you may be back there next year too.
Might have to, yeah.
All right.